Good afternoon and a warm welcome from my side to our event, The Time for Feminist Global Health Policy is Now. My name is Nina Bernarding. I'm one of the co-founders of the Center for Feminist Foreign Policy, a research, advocacy, and consulting organization that promotes an intersectional feminist and people-centered approach to foreign policy. Because we believe that foreign policy can and should be a mechanism for equality, justice, peace, and solidarity. Over the last years, we've seen an increasing number of countries either implementing or considering implementing feminist foreign policy. So for example, Sweden, Canada, Mexico, most recently Spain. But many of them fail to include feminist health policies into their approaches and framework, beyond often a focus on reproductive and sexual health and rights. Civil society across the world, however, is clear. A feminist foreign policy does not mean feminist perspective in one, but in all policy areas. The access to healthcare is a human right, which is central to and dependent on the achievement of many other human rights, such as education, food, and political freedom. With its historical roots in tropical medicine and imperialism, the current global health landscape is shaped by major power imbalances and fails to ensure that everyone has the same access to quality healthcare. Not only are women, LGBTQI individuals, and people from the global south underrepresented in international global health policy decision-making processes, but their health needs are often not accounted for, underfunded, or restricted. This reinforces discriminations against already marginalized groups, and it restricts their access to resources, privileges, and opportunities to shape and participate in our societies. For these reasons, we are really proud to launch today our policy brief, A Feminist Global Health Policy, which is available on our website, and to discuss this topic with you and our amazing experts today. We hope that we, both with the policy brief and the feminist our discussion today, we aim at contributing to the emerging discussion on a feminist global health policy. So how will today's event look like? In a second, I will hand over to my colleague Annika Kreitlau, who is the main author of our policy brief, and she will briefly outline you why we need a feminist global health policy and how this could look like, before we enter into a short panel discussion with our two amazing experts here. We will then open the meeting for Q&A, and we will close the meeting by 5:30 p.m. Berlin time. You can either use the chat function, or you can also speak and address your questions directly to Annika or our external speakers. And now it's my great pleasure to hand over to Annika. Annika, the floor is yours.
Thank you so much, Nina. And yeah, thank you for the opening, and also a very warm welcome from my side. I'm really happy and really grateful that so many of you came out and took some time out of your really very busy schedules to be with us here today and to listen to this very important conversation we're planning to have now. So to kick off the discussion, I just want to give a brief overview of what we as the Center for Feminist Foreign Policy mean when we speak about a feminist global health policy, and what this could look like and what policy recommendations we would propose. Before I will start, I just want to re-emphasize that this concept or the idea of extending feminist policies on a global health level is not something new or something that we just came up with on our own. We are building here on the work of numerous organizations that have been working on different aspects of this and all of this together for some time now, and we're trying to bring all of this together a little bit and extend on this. And for us, this is kind of like a first toe in the water, I would say, and trying to bring feminist foreign policy together with health and global health policy. So let me tell you a little bit about our briefing and the actual topic it's covered. We did call it a feminist global health policy, but to be honest, it goes a little bit beyond the classic definition of global health. It also talks a little bit about public health, gender medicine, and some other aspects of it. So it's not only focused on global health policy, but also to other aspects, and definitely on foreign policy. Speaking of which, Nina already mentioned that one aspect that is covered by most of the frameworks or white papers from countries who do have a feminist foreign policy, like Sweden, Canada, and recently Spain, they do talk about one aspect, and that is sexual and reproductive health and rights. It is an issue that is highly political and also very crucial, and it demonstrates the interconnectedness of health and foreign policy, and as well as domestic policy. We know from so much research that when access to contraception and family planning options, including abortion, I want to be really clear on that, when they increase, that the woman's literacy and economic status also improves, and that a general increase of women's health is also tied to an increase in GDP and the economic performance of a country. So we do know that it's a very crucial aspect and it is incorporated. But however, we see that like most of the feminist foreign policy approaches fail to look at it from an intersectional perspective. It mostly covers only the rights and needs of heterosexual cisgender women, and also fails to account for the disproportionate effect of women of color, for example. And so we definitely need to extend the approaches to sexual and reproductive rights onto an intersectional perspective. And also, let me be clear, a feminist global health policy is more than sexual and reproductive health and rights. There are so many other aspects of health and health policy that would need a feminist approach. So let me spend some more time talking about this. And one thing that is really important and is global health power imbalances and the leadership and the question who actually holds the power in global health policy making. I don't want to talk too much about numbers and the status quo because I know that Sarah will be talking about this and she's really the expert on this one. But I just want to, let me just say one thing really clear. Global health itself is a study of inequalities. It's a landscape where some countries and also some private companies and private donors have a lot of powers and others don't have any power. And it's those countries with a lot of power that shape the entire landscape and decide upon the fate and especially the health of the people in the other countries. And the axis of the COVID-19 is just the tip of the iceberg, where we see very clear how disproportionately like the distribution of the vaccines is going at the moment, and that it's actually countries from the global north who are blocking the access for other countries from the global south. And all of this is very connected to the way decision-making boards are structured and who are actually the people who are making decisions in global health. So the way we understand feminism, of course, from an intersectional perspective, it also has to come together with the movement to decolonize global health and to actually deconstruct these power imbalances within the global health system. But as I said, we don't only want to talk about like the bigger global health system, but also health on like an individual country level and health on discrimination within individual healthcare systems. So there are so many things where discrimination is happening in healthcare system. I'm not trying to give you a complete list. I just want to give you a few examples. Like we can see, for example, that maternal mortality in the UK is about 4 times higher in Black women than in white women. We can see that Black individuals are much less likely to be diagnosed with the proper usage of diagnostic methods in case of cardiothoracic pain, so like heart pain. And we also see, or we also have reports that at least 30% of all LGBTQI individuals in the US report of experiencing previous discriminations within a healthcare facility. And this is only the people who report on this, imagining like the number of actual people who are experiencing this might be much higher. So there are many, many reasons for this. It comes down to structural as well as individual discrimination of the healthcare systems. There are healthcare professionals who are actively not taking, for example, the concerns of Black women seriously, who are neglecting their pain, but there's also a system that fails to acknowledge the needs and is just very unequal in its structure itself. Also, just listing more inequalities, there's a lack of research and there's a lack of sex and gender disaggregation of data. And this is very crucial, because if we don't actually disaggregate the data and don't create the data of the inequalities, then there's no way to improve it. So if we want to talk about policy recommendations, one crucial step is to actually invest in research and make sure that all the research that we do is disaggregated with regards to sex, gender, but also racial background and other forms of discrimination. And lastly, one aspect that is oftentimes forgotten, or let me say neglected when talking about gender and health, is the harmful effect of gender stereotypes, and in particular, toxic masculinities on health. We have to just take a short look on all of health statistics, basically, and we see that men suffer greatly under the patriarchy. They live on average about 5 years less than women. They have much higher suicide rates, higher levels of drug and alcohol abuse. They are just much less likely to take preventive healthcare measures, to go see a doctor, or to seek mental health and therapy. We are convinced that this is deeply rooted in patriarchal stereotypes. For example, the fact that men are being seen as like strong and not vulnerable and not able to ask for help. So if we want to have a feminist global health policy, we have to address men's health as well and advocate for the deconstruction of harmful gender stereotypes and its effect on the health outcomes. So to sum up, before we go into the actual discussion, let me say what we mean when we talk about a feminist global health policy. A feminist global health policy for us, it's grounded in a people-centered and human rights-based approach. It acknowledges the human right to health at its core value, and it places the needs of the most marginalized at its center. It strives to question and reshape power dynamics in governments, global health institutions, as well as medical facilities. It applies a thorough understanding of gender as a social construct in all levels of global health decision-making and actively deconstructs toxic masculinities and harmful gender stereotypes. A feminist global health policy strives to achieve universal health coverage for all people, regardless of gender, race, sexual orientation, or socioeconomic status. Thank you. Back to you, Nina.
Thank you so much, Annika, for giving us this really great overview. And I can just encourage everyone to read up on the policy brief that Annika has been drafting, because in addition to what she just outlined now, we've also listed a lot of policy recommendations that states can and should adopt both on a national but also on a multinational level. And I think I just want to come back to one point that you've made, is that it both is the inequalities that we see is both a consequence of structural but also personal choices. And I think one of the most interesting points that I found in your policy brief is that in particular when it comes to discrimination against LGBTQI people, this is the direct consequences of governance making a decision of whether or not to adopt to acknowledge gender as a social contract and to move beyond the binary construct of a woman and a man. And this is how this is translated into the praxis. And I think, Sarah, maybe you can say a bit more about this, because your organization has just been published a report to look into which global health organizations are actually using a definition of gender as a social construct. And I think the numbers were quite shocking. So having said this, I have now the honor to introduce our two panelists here. So we have with us Dr. Zara Zanali. She's a global health professional from Iran. She studied at Iran University of Medical Science and Johns Hopkins Bloomberg School of Public Health. She's currently working with Global Health 50/50 as a researcher and with the Rockefeller Foundation Boston University 3D Commission on Health Determinants Data and Decision-Making as a fellow. And the organization Global Health 50/50, which I was also just referring to, is a research collective, and it's mainly based at the UCL in London, but with a huge number of volunteers from all over the world that work to advance action and accountability for gender equality in global health. And Zara's research focuses on health system and policy, gender, and intersectionality. She has previously worked with the Health Workforce Department of the WHO, so the World Health Organization, the EAT Foundation, and the International Federation of Medical Students Associations. Thank you so much for being here with us today. We also have Mullio Alvarez here. He's a health officer with Transgender Europe, a member-based organization with 157 member organizations from 47 different countries that works to strengthen the rights and well-being of trans people in Europe and Central Asia. Originally from Spain, Leo has a background as a psychologist working with trans communities and as a trainer on gender diversity. Most of his activism has been supporting the development of legal gender recognition in Spain with a focus on self-determination. In his position as a health officer, Leo is committed to raise awareness of depathologization of trans identities, working towards it and making healthcare accessible for all, for all trans people. So Leo, maybe before we start, maybe you can just help me explain what does it actually mean with the word that I just struggled. Yeah.
Hi, well, thank you for the invitation, first of all. I'm happy to explain this word. I was actually gonna talk a lot about it later, so it's good to have the basics now. Pathologization means understanding the identities of trans people as a pathology. And that has a lot of implications, and I will talk a bit about that later when we see what discrimination looks like for trans people in the healthcare system. That has a lot to do with the idea that being trans is some kind of illness that you can measure so that it can be externally evaluated and you can be trans or not. And there's a diagnosis that's associated with being trans actually, and that's required to exercise many rights for trans people, such as healthcare, but also legal gender recognition or other rights. And this is a historical issue that we've been dragging for many years. Trans people have been perceived as pathological since kind of the beginning, as when trans identities were conceptualized. It came from the medical field, explaining what trans meant. And that's where we're kind of still dragging this idea that being trans is a pathology.
Thank you. And I think with that, we're already starting with the first question. And in the first round of questions, I want to focus a bit on this, what is the status quo? And I mean, Annika already outlined a couple of inequalities within the international global health system. But as you've just mentioned, Leo, transgender people are an especially vulnerable group who suffer tremendously through discrimination within our healthcare systems. And you've just outlined one of the main issues, I assume. But can you elaborate on this a bit more? And how are the stigmatization and the discrimination that trans people have to suffer through the societal and political life are being perpetuated in the healthcare system?
Well, unfortunately, discrimination is still very present for trans people when trying to access the healthcare system. It happens at different levels. So when it comes, for example, to general healthcare, so primary care or even any type of specialized care that anyone has access to, we see that medical professionals and other staff are often unaware of gender diversity. So they don't really know what this means, what it implies for people. And so they don't really understand what being trans means or what the experience of trans people may look like. We see that prejudice and stigma are still very present, and that many trans people are mistreated in these settings, both personally, so in their personal treatment with providers, for example, when they don't get their name or their pronouns respected by providers, or when they are questioned in their identity. So even if you say, hey, this is my name, this is my pronoun, this is my gender identity, that doesn't mean that will be respected. On the opposite, often we find that we are questioned, that we are we're not enough, our word is not enough for people to respect what we're saying. And because of this pathologization that I was just explaining, there's this idea that someone else has the authority to decide if we are really what we're saying we are. So if we are really a man, a woman, or non-binary, which is something that is not even considered by people who aren't aware of trans issues, of course. And it's up to them to decide if they want to respect our gender or not. So this, of course, impacts our just the personal treatment that we receive when accessing care, but also, as Annika was explaining, with other issues, it also it means that there's a series of assumptions and prejudice about our experiences that will also bias medical interventions. So what options for care we're offered, or how we're treated, or how treatments are carried out, it has a lot to do with how people understand what being trans means, and all of the assumptions that come together with the social construction of gender. One example for it would be, for example, when it comes to sexual and reproductive health, so that certain people may not receive the information they need or the treatment they need based on false assumptions about trans people's relationship with their body or with their sexuality, or that our needs are maybe disregarded. For example, when it comes to HIV care, for example. There are also other forms of structural discrimination. So you were also mentioning the link with healthcare, with other rights as well, and how inequalities there are course, influenced by access to other rights. And for example, when it comes to trans people, we see the impact that legal gender recognition has. So if trans people, if we are allowed and able to actually change our gender marker in our documentation so that we are officially legally recognized in our gender, and therefore we can also have access to our name that corresponds with our gender, the impact that has on our access to healthcare is huge. Otherwise, we won't have our name or gender respected or reflected in our medical records, and it's also a way of supporting us in that daily discrimination in care. But also, structural discrimination comes in the form of the direct exclusion of trans people from certain services, or from specific groups of trans people from healthcare. In that sense, there's a whole issue with access to trans-specific healthcare. So all of those treatments, interventions that are related to transition, to medical transition that some trans people needs, that includes hormones or surgery that some people need. And we see that the coverage of those is still an issue in many places. So even those in those countries where this is covered, the process of accessing is heavily pathologized, meaning that trans people have to go through a series of psychiatric evaluations in order to be diagnosed. As I was saying before, you need to fulfill this criteria of what being trans means medically for them, and also to their personal or subjective understanding of gender. And if you fit that criteria, then you will be allowed to access certain services, and if not, then you're automatically excluded. So this is not only discriminatory and painful for trans people, but it also leads to, we are seeing very long waiting lists in many countries, and also the exclusion of all of those who do not fit the criteria for being trans, or the views of the particular medical professional. We see that specific groups such as minors or gender non-conforming people or non-binary people, disabled individuals as well, or those with mental health diagnosis are systematically excluded from trans-specific healthcare. So here we have a huge problem with gatekeeping that's preventing many people directly from even accessing healthcare. No, I will stop there because I can go on forever.
Yeah, but thank you for giving us this overview. I think this is very important for us to understand the challenges and the discrimination. I mean, maybe some of you who are here with us today have heard about, I think it was Arkansas, the US state, who've just stopped providing, well, I think it's gender, well, Leo, maybe you can help, but it basically adequate health services for trans children, right? And that was a very pure political decision, and it will have like very, very dire consequences for health of many children in the state. Yeah, so now I would like to move to Zara. Global Health 50/50, so the organization that you're working with, just recently launched its report Flying Blind in a Time of Crisis, which analyzes gender equality, representation, and gender transformative approaches within the global health landscape. So what are the most maybe pressing, but also most depressing findings from the recent report? So what are the biggest gaps that you've identified in this report?
Thank you, Nina. Hello, everyone. First of all, I'd like to thank you for extending this opportunity to me to present the work of the Global Health 50/50 Collective and the findings of our 2021 report, as you mentioned. Global Health 50/50 is a research and accountability initiative based at UCL and founded by Professors Sarah Hawkes and Kent Buse, and run by volunteers. So as you mentioned, the report examines the current global health status quo as it pertains to gender equality in the work that the global health organizations do, as well as what they do within their workplace itself. So for the 2021 report, we assessed 201 global health organizations on 14 variables across 4 dimensions that included commitments to redistribute power, equitable outcomes, and power and pay, tackling power and privilege imbalances in the workplace, and taking a gender responsive approach to improving health. And here I'd just like to briefly highlight some of the report's, interesting findings. So we've observed that the stated commitment of global health organizations to gender equality has grown steadily since 2018, when we first started publishing these annual reports. Today, 79% of organizations in the sample commit to gender equality, which is great news. Organizations that state what they mean by gender are on the rise, but still only 40% of the sample define gender in their public communication. And while we applaud the progress that's been made since 2018, we highlight that the majority of organizations are not seizing the narrative power of defining gender as a social construct in their policies and strategies. And then, despite the strong rhetoric, only 60% of organizations have transparent gender equality policies for their workplace, of course. Even fewer have diversity and inclusion policies, standing at 51% of organizations. Moreover, a small fraction of organizations have transparent board diversity and inclusion policies, so where the power is really concentrated, the decision-making power. And then again, within the workplace and for the employees of these organizations, transparency of anti-sexual harassment policies and family-friendly policies is low but growing. We've noticed that organizations are adopting a gender-responsive language on their core programming, with 39% of organizations positioning the work that they do in relation to transforming gender norms and gendered systems and structures that stand in the way of better health outcomes for all. 39% is still not too much, but it's been growing, so we're happy about that. And lastly, we have unfortunately observed that COVID-19 programs are flying gender blind, that's kind of where the name of this year's report comes from. Over 80% of COVID-19 health programming activities do not recognize how gender affects people's health, even though there is ample evidence how this disease is gendered when it comes to mortality and morbidity, ICU admission, and severity of disease. Unfortunately, we've realized that support across a range of WHO recommended areas of pandemic response that include vaccine development, prevention, access to treatment and care, health workforce protection and surveillance, were found to be largely gender blind across the world. I'll stop here and share some more figures and data with you later. Thanks.
Thank you, and thank you also in particular for highlighting again the impact of the pandemic. And I mean, what we've also seen is that countries like the US, for example, have used the pandemic as an excuse to restrict access to reproductive health services by declaring, for example, the access to legal and safe abortion as non-essential. So I think it's not only that they were flying gender blind, basically, but also that they're using it actively to reinforce their narratives and their strategies. And I think this is something we obviously always need to take into account. So now, bit moving on from what is wrong in this really big field, and I've understood that there's a lot of wrong. If all countries were to adopt a feminist global health policy, how could this contribute to making the health system a bit more equal? And I would like to start with you, Annika. I mean, you've touched upon it a bit in the beginning, but what do we mean when we say a feminist global health policy? Why don't we just call it an equal health policy or a fair global health policy? So why the feminism in there?
Yeah, thank you for that question, Nina. I think actually it's a quite central question because I'm quite young, but from what I know from the global health field and what I've experienced so far is that a lot of people talk about these issues that we're just talking about right now, but I haven't actually seen the mentioning of feminism that much within global health. There's a lot of talk of gender equality and just like you said, like equal health policy and stuff like that. but yeah, the word feminism is lacking, I would say. And to me personally, it's really crucial. And I think Nina would agree with me that this is also CFFP's approach. And well, I guess it comes down a little bit to how do we define feminism? And we did try, like, it's quite impossible to actually do that, but we did try that at the CFFP within our recent glossary, where we said, and that is the one key point that I want to highlight, is that we understand feminism as a tool and as a kind of way to look at the world and the way that power hierarchies and power is structured within the world that we live in. And for me, a feminist global health policy is exactly that, taking that feminist look and that feminist glasses, I would say, and applying them through, like, on the world of global health. And yeah, like I said, it's actually applies to all levels. It goes to leadership, like who is represented, who is in the leadership position. So we have to advocate for gender parity, like, as one really simple step. But we also have to talk about not only gender parity, but also perspectives of non-white people, but also people from low and middle income countries, and so many other things. And we also have to acknowledge gender as a social construct. And then it comes down to the research. We have to have actually gender analyzed and sex disaggregated data, also race disaggregated data. And so, yeah, what my idea of feminist global health policy or our idea at the CFFP is just taking these feminist glasses and applying them to every single policy decision that is made within the global health system. Yeah, so I guess that's my answer.
Yeah, and I mean, maybe I can just add to this. I think it's really about the power dynamics and about understanding that this is not just a coincidence of how it's set up, but that it's been set up in a way that it's benefiting certain groups of people. So I think this is crucial in understanding also how we can overturn this. Sarah, I just want to come back to this question on research, because I mean, Annika mentioned it in the beginning, and I think also in the policy brief we've mentioned that it says that research is not neutral, and that the male body, and I think it's also the young male body, has been used as a standard in order to treat, to understand symptoms, but also to treat, to test medicine and medications, and to understand how the body reacts to this. And so why is it so important that we speak about this issue? And why is it also important, as Annika mentioned, that we have gender and sex disaggregated data? And why do we need also change in basically the basis of what then becomes global health policy?
Thank you. Thank you for the really interesting question. I think in Global Health 50/50, we always sort of emphasize the importance of adopting gender transformative approaches. And I just like to start with sort of defining what we mean by gender transformative, and then moving on to sex disaggregated data. According to the WHO, gender transformative approaches recognize that gender drives health inequities and health outcomes. And these approaches aim to transform the harmful gender norms and systems and structures and power dynamics that create these disadvantages and discrimination, and fosters gender equality. Gender transformative approaches are not only the just and fair thing to do, but they directly increase the effectiveness and impact of interventions that improve everyone's health. Organizations that are working in global health need to examine how they can take an increasingly strategic approach to shifting their power dynamics and tackling oppressive gender norms to advance the health of everyone. And therefore, I believe, and I think I'm not the only one who believes this, that the first crucial step is data disaggregation. Obviously, we can't improve what we can't measure, and data disaggregation is just fundamental to the full implementation of the UN Sustainable Development Goals, fulfilling the ambition of leaving no one behind and delivering health for all, or as more widely known, universal health coverage, organizations need to report on and recalibrate their programs based on data that is disaggregated not only by sex, but by other intersecting social stratifiers, including race, class, geography, age, and ability or disability. It's crucial to realize that our feminism needs to be intersectional. Our methods and solutions must acknowledge the compound effects of intersecting social identities and locations and allow for empowering those who are most vulnerable. However, in reality, data shows that only 39% of global health organizations publish sex disaggregated data, a proportion that has not changed since 2018. So this is obviously a huge gap that we really need to sort of try to mend in any position that we're working on. On a more positive note, though, in 2021, we noticed that more organizations are publishing gender-responsive health approaches, with 39% of them adopting gender-transformative approaches. So on the spectrum of gender-responsive approaches, gender-transformative approaches are sort of the gold standard where they actively, work on transforming gender norms. And I think as a last point to this question, I'd like to mention diverse perspectives in global health. According to our 2021 report, male privilege in global health still pervades, as we've all seen and we all know by empirical data as well. Even though global health sector has to lead on equity and justice, but it's unfortunately not the case. Our data show that men continue to hold 70% of leadership positions, and as Annika mentioned, nationals of high-income countries, even more so, they hold 84% of leadership positions. Contrasting that, women from low and middle-income countries hold only 5% of global health leadership positions at the moment. We need to transform this culture in order to better serve people of diverse backgrounds, who are our main target with global health, regardless of what country we're operating in. Leadership that reflects the global community it is serving is more likely to bring relevant and diverse experiences, expertise, and lived experience to the challenges that global health is facing. And organizations must challenge, hold the mirror to themselves and start with themselves, and challenge inequalities in power and privilege in their leadership and management if they're truly committed to a human rights based approach to health. So in conclusion, if there's one word to take away from this part of my answer, is to absolutely always sex disaggregate, and if possible, gender disaggregate, and analyze your data to create a more nuanced image of what we're dealing with in global health.
Yeah, thank you so much. And then, I mean, when you hear these shocking numbers of men from high-income countries dominating the decision-making processes, then it's also no wonder when you hear that the diseases that men suffer from are over-researched, are often more researched than any diseases that mainly affect women, for example. So this is why we obviously need diverse representation. Leo, I also want to come back to you. So, where do you think feminist global health policy holds promises for trans people? And so how can a feminist global health policy also contribute to improving the health situation of transgender individuals?
Well, I think we're working towards the same goals, and I think, and I was very happy when I heard Annika, because I hadn't had a chance to look at the brief yet. But I think it's just so inclusive. It's great to hear, especially in these times we're living, to be speaking about feminism and about trans issues together. So I think feminist global policies need to take into account the needs of trans people, and now they were mentioning about research, then to see how that's included there. I also wanted to mention that I think just alliances. And so we've talked a lot about intersectionality, but also I think alliances within movements, groups, how to work together towards that. I think it's we're in a time where we really need to be looking at how to do that better and how to get closer, and see what goals, shared common goals we have right now. So I think definitely, like you've been saying, we're talking about how the social construction of gender impacts and oppresses so many people, including trans people as well. So I think we are speaking about the same things, that we have the same lens. I really liked when also Annika explains about what feminism means and what the gender lens that it brings to all of this work. And you know, we are we're going through the same struggle. We are facing the same structures that are oppressing us, and we share the feminism lens ourselves. So we hope that feminism and all these policies will also take into account that and include the needs of trans people. And also I would encourage everyone here today, wherever you work, to reflect on how your organization can be more inclusive of trans people's rights. We've talked about representation, we've talked about research, advocacy. So what are all these things that we can also do ourselves as civil society organizations to be really representative of all the community we're working for?
I couldn't agree more. And I think also, I mean, I don't like to make a distinction between feminism and trans rights, because for me, feminism includes the rights for trans rights. But even if I even would say that if we include the trans perspective can help us understand how patriarchy discriminates against women. So I think there's just no point in not working together and not understanding, as you said, that we're working together. So Leo, if you could wish for like maybe 2 or 3 things, and if you could envision a feminist global health policy, and in particular for organizations like yours, where would you like to support come from first, and what would you like to see to change really quickly?
Well, if I think of trans organizations generally, I think how under-resourced and underfunded trans organizations are. So I think that's a big part of the work there, that we need to get financial support so that we can survive as organizations. The difficulties we're facing are just so much that it's very difficult to be sustainable right now. And especially as it's been mentioned with COVID is having a huge impact on the community, something that I hadn't mentioned before. And I think it's very important to name it. And other than that, again, I'd say human support. So like I was saying, really changing how trans issues are understood, and to understand that this is a fight for justice, but not only our fight, but everyone's fight. So to do that reflection that I was just mentioning, and seeing how we can so not only be more inclusive in our organizations, but also how we can work together, reach out. We're here. We're happy to find ways of working together. And I think the goal for us would be that all people have access to care, especially when it comes to trans-specific care, that it is available and covered for all trans people. You also mentioned the impact of COVID, and some needs seeing as not essential. That's happened also with trans people's treatments and surgeries. We've seen so many people being denied access to that because of COVID, and trans-specific care not being perceived as essential. So I mean, we're basically asking for care on the basis of self-determination, so that we finally end up with this gatekeeping and pathologizing model that we currently have in most places, so that everyone can just access care on the basis of self-determination and informed consent. And so we need policies, we need very detailed medical protocols for that, and we need also accountability mechanisms for when that doesn't happen, so that we can keep people accountable and make sure that trans people are protected.
Yeah, thank you so much. And I think it's a really good point that you've also pointed out that the health services, obviously the pandemic also impacted and trans gender people. And I think something, so CFFP has been working for a couple of years now on the Women, Peace and Security agenda, which some of you might know, but it's 10 resolutions by the UN Security Council that address the role and the perspectives and rights of women within the prevention, resolution, and reconstruction of violent conflict. And what we've been trying to do is also to highlight that it's not only women who suffer disproportionately in violent conflict, that it's in particular also LGBTQI people, and then also in particular transgender people. And we've seen with the US under the Trump administration, we've seen them lobbying quite heavily against the provision of health services for survivors of sexualized violence in conflict settings. And this was, even then they only talked about women, and the civil society was really clear on that this cannot, first of all, it should be in there, but it should not only be for women and girls, it should be for everyone who needs this, and in particular those who are being targeted disproportionately. And what we've seen, and we're currently starting also a project on the rights and perspectives of LGBTQI people within WPS, is that it's not only women who are being targeted in violent conflict, for example, for sexualized violence, but it is also transgender people. And I think this is often being forgotten about. And I think this is also the homework of organizations that work on women, peace, and security, to highlight that we need to have a really intersectional understanding of the gender discriminations within this. Sarah, one question for you. If you could envision a feminist global health policy, what would this look like? And where would you like to see changes most quickly?
Certainly, thanks. Thank you for the question. So I think there's already certainly growing recognition and a lot more buzz around feminist policies in global health and mainstreaming gender beyond sexual and reproductive health. However, I think as we discussed in this panel, action is consistently lagging behind the urgency required to see actual change happen. And inequities exist across sex, gender, class, race, education, geography, income, and other categories that are relevant to global health. A feminist approach to global health must promote inclusive participation and reform through formal and informal culture change, as I mentioned before, in organizations, but also, as Leo just also touched upon, accountability of actors and stakeholders towards the communities that they serve and the staff that they employ is crucial. Especially the global health workforce is predominantly made up of women, but led by men. And women are concentrated in lower paying jobs and held back by systemic bias and discrimination when it comes to taking on leadership roles. Their labor must be compensated adequately and their experience valued, in order to advance global health for all. So I believe a feminist global health policy should utilize feminist and intersectional research methodologies to identify gaps, should be committed to institutional reform and progressive change in leadership, where leaders come from diverse backgrounds that reflect the population. Steps must be taken to address the disproportionate concentration of women in lower levels of the workforce hierarchy, and sustainable change needs to come from non-tokenistic and participatory leadership of those who are less represented at the moment, especially women from low and middle income countries and other minorities. And of course, again, as Leo also mentioned, resource allocation and funding, it must match the ambition to close gender gaps in health outcomes. It must be evidence informed, and it must be monitored and evaluated through a feminist intersectional lens. So as the final word, I believe there's a strong momentum in global health right now to acknowledge its shortcomings and persisting inequalities and inequities. And it's upon every single individual, institution, and government to reflect and commit to doing better and doing more by learning from the wealth of resources that are available. And to name a few, we have the Global Health 50/50 toolkits and reports and the briefing that you just published today. So there's a wealth of resources. We just really need to take action. And I really like the word that Leo mentioned, alliances within the movement. I think that is the crucial step to amplifying all the efforts that we're making. Thank you.
And thank you for pointing out that the resources are there. And I think this is also the point that Annika was making in the beginning. only because the momentum is growing, it doesn't mean that not a lot of people have thought about this for a very long time, and that it's now really the time for action. I just realized when I spoke about the women, peace and security agenda, I should have been more specific when I spoke about women. What I meant is that the focus was on women only. I meant cis heterosexual women. So I'm just also in terms of trying to be an ally, I obviously have a lot to learn. So acknowledging this and trying to improve myself for next time. I want to focus. I want to close with Annika. And maybe I can already ask you to address one of the questions that was mentioned in the chat function. So first of all, what's your vision for a feminist global health policy? But then also, there was a question about mental health, and I know that in your policy briefing you touch upon it, but maybe you wanna say a couple of things on this. And then for everyone else, if you have questions, now is the time.
Yeah, thank you so much. And I think a lot has been said with concrete ideas and concrete visions. I just want to also touch upon the point of alliances and bringing the movements together, because one thing that we did mention sometimes, but we haven't spoken that much on it, is the movement to decolonize global health. And I think it is also really crucial to combine feminism and decolonization and deconstruction within global health systems. And I just saw a tweet, some of you might have seen it last weekend, by Madhuka Pai, who's a really famous and awesome global health professor I'm a really big fan of. And he said, the global health system is not broken, it was built this way. And I think this is the essence. Like, a lot of the inequalities and the power imbalances within global health have been there from the start, and from the building, and are deeply rooted in colonial times and colonialism and a lot of these things. So my vision for a feminist global health policy would be like a thorough deconstruction of the way that all of this is built, and just dismantling the whole system and rebuilding it on an equal human rights based approach, and centering or focusing on the most marginalized and putting the needs of the people at the center, and working together towards the common goal of achieving a global health for all, or universal health coverage. And on the question of mental health, I did talk about a little briefly in the briefing, but it's a really complex issue, and it's also within health. I think it's still neglected. There is growing work on it, and Germany is one of the countries who's a little behind it. Like, we don't really talk about mental health as much as, for example, the US does, but it's really important. And one point that I personally always remember, because it for me it shows a lot what the issue is, that I mentioned in the beginning, that men have higher suicide rates than women. But also, when we look at the way, and maybe I should give a brief trigger warning, because I want to talk about the suicide fact just for a second. But so when we look at suicide, and that men actually commit suicide much more effectively than women do. So we see a lot of failed suicide attempts by women, who are taking, for example, pills, and then they don't, the suicide is not successful. But for men, they take much more severe measures, and so they're more successful in the way they commit suicide. And at the same time, we see a lot of more women who are actually going to therapy and having mental health interventions, and actually doing something about their mental health issues. And women, and also I think LGBTQI individuals, are also more prone to take up mental health issues than heterosexual men. So I think this fact mirrors so much the problems that we have, that the stereotype of men being strong and not having feelings, not showing emotions, and all of these things is making it's so hurtful, that apparently there are some heterosexual men who are so incapable of asking for help that the only measure they see is to commit suicide. And the numbers are there, and the facts are there. And so this is one thing. I know when we would talk about mental health, there are so many other things, but this is just one thing that stuck with me for a very long time, because I find it so shocking, to see this discrepancy between men and women. And
Thank you, Annika. And yeah, and I mean, you can read upon, in the policy brief, there's a whole section on how patriarchy also affects the health of men, and then also how the toxic masculinity gender stereotypes that prevent men from seeking mental health issue, how this is then again impacting the health of LGBTQI individuals or women. And so, yeah. There was a question in the first question was actually, maybe Sarah, that is a question for you. Who would you suggest to best address with these policy recommendations? So which entity basically in the global health landscape? Is it the ministries on national level? Is it UN bodies? Is it international organizations? Is it all of them? So
Thank you for the question. Yeah, I think all of the above. As I mentioned, I think this is a much larger task than any one entity can tackle. And these policy recommendations, I understand that policy recommendations are varied according to who they target. Is it a UN system? Is it a government? But I mean, essentially, there's a lot of different recommendations that any organization or individual can take upon themselves. Some have access to powerful people and stakeholders. Some have access to funding, and then some are just passionate individuals. And I think, you know, in a sense, the more upstream change comes from, it seems like it must be easier and more effective to cover a larger proportion of population. I think that is true. But just because we may not all have access to that highest level or most upstream sort of measure of acting change, we can still do a lot on our own. So I really encourage you to have a look at the policy recommendations of this briefing, of similar websites. I think there's a little bit for everybody and any organization to consider.
Yeah, and I mean, I would definitely agree that there's need for change on all of these levels. So I mean, I know for Germany, for example, Germany last year, I think they finally banned conversion therapy for minors, but they haven't banned it for people over 18. So I think there's still a lot to do on the domestic level, but there's also obviously Germany could also use the leverage that it invests in the World Health Organization to lobby for equal participation or for more research on diseases or health challenges that affect, for example, transgender people. So I don't think it's either or, as you said. There was one question, Leo, maybe you want to take it, how we can best empower women and other diverse communities. And I'm not the biggest fan of the word empower, so I will rephrase the question if that is okay, how we can best support women and other diverse communities. And maybe just as a background, for me, I mean, empower always implies that we'll need to fix and focus on women or on transgender people instead of focusing on the structure. But I obviously do think there's a lot of legitimacy and also need to talk about how we can support these groups. Yeah.
I agree, Nina. Thank you for saying that. I was also thinking about everything you mentioned before about decolonization and how I don't know what people need or where they need support for. So we need to ask them what they need and how we can support them from our position. And I wouldn't be able to say what trans communities need. It really depends. And also trans communities are very diverse, as we've been talking about for women or for all minorities we've been mentioning so far. So even starting from the most basic to the more higher level needs, we have so many different situations. We have, and now especially with COVID, there are such basic needs that are not being covered with food, shelter, the very difficult situation of employment and sex work as well. So there are just so many barriers right now to just having the basic needs covered that, you know, a lot of work has to go there. And then we'll also see in terms of advocacy and policy priorities where we are. And for that, we also need to be in touch with the community. So just making sure that we're not leaving anyone behind, that we're really asking and in touch with everyone to really know what they need support with, and then see how we can get there.
So basically nothing about them without them. Yeah, I think that's very crucial in making sure that they can drive, that we can use I mean like now also as a CFFP organization, but reflect on the privilege and the access that we have, and then ensure that we can use this to center the discussion on the perspectives and interests and needs of marginalized groups. Annika, there's a very complex question for you, and it's about on the overarching philanthropic mindset, which disempowers active communities and it feeds into this white savior complex, which is so prominent in global health. And now I feel honored that someone is referencing what I said in a podcast once, but that gender is not only looking at the binary divide, but it's about recognizing the way that the male or the female divide affects many areas of our society. And I think, if I remember correctly, what I wanted to say is that obviously gender is a social construct, but it's also a way of structuring activities and relationships and people based on what we assume with what we perceive as male and what we perceive as feminine. So activities that are being perceived as feminine are less valuable than any activities that are being considered as masculine. So we'll also need to keep this power construct in mind. And yes, you want to reflect. I mean, Annika, we also in the policy brief, there is a section on private companies, which is problematic, but they're the only part of the question. So yeah, maybe you want to take it away.
Yeah, thank you. Yeah, it's a very difficult question because maybe I can share this. We discussed beforehand that like we were not so sure if we should also talk about private money in global health, and it's like everybody who's working or has some experience in the field knows that there's a lot of private organizations coming up within the last, I don't know, 20 years maybe, who are financing a lot, which also has a lot to do with the fact that governments are less prone to give money to the UN bodies, for example. So this one of the main reasons that governments are not doing their job by like doing the research and investing in global health. So there's all of these private organizations who are coming up and who are taking up the work and who are doing it. And so this is, I think one of the causes of this is the fact that governments are not committing to it, and this would also be a solution, like definitely for more governments who are like democratic, accountable organizations, for them to take up the research and the lack in global health. And yeah, with the influence of private organizations, I mean, we can all agree that there's a lot of progress because of the way that private organizations have invested in global health, and who might be more prone to progressive issues than governments. But like I'm not so sure if this is a general statement. But if we want to have an equal and fair global health system, I think we have to rely on the organizations that are democratically elected and that are not built from a capitalistic unequal system that is totally prone with inequality. So for me personally, I don't think that private organizations are like the solution to inequality within global health, but they are more of like a symptom of a system that has many gaps. And that I think so. But I mean, feel free to, I don't know, Sarah, if you have an opinion on that. I think it's quite hard. Yeah,
Sarah, do you want to come in on this?
I think Annika said most of what I had in mind. I think we're thinking along the same lines.
And I think what also in terms of the white savior complex, I think if we look about the vaccine debate at the moment, I think that is a very good example of there's unwillingness from the global north countries to share vaccines from the beginning, but they talk about how great they are in sharing then what's left over, or of giving very small very small numbers of vaccine doses to certain countries, mainly in the global south. And I think that there you can see very strongly the difference between if there would be equality and everyone would have the same access and resources and opportunities to get these vaccines, or if there are some countries who depend on other countries of then giving these vaccines. And I mean, to be fair, these countries often also just give it because it makes them feel better. And this is not only a human rights problem, it's also obviously a health issue, because what we've seen, if there are countries with high rate of COVID, with COVID cases, like in Brazil, we see the mutations and all of this. So it's just from so many opportunities, it's just really, really stupid and mean and not the right thing to do. And I think also this annoys me also when everyone is now talking about the US and saying like how much what kind of high rate of vaccinations they have. Yes, this is great, but this comes as a very high cost, because although Biden did not call it this way, and I don't want to put words into his mouth, but what he basically did is America first. And so I think this is really important that we make that we differentiate between equality and then about even good intended support. That is not the same, and we're not gonna. We want we want equality, and we don't want, goodwill or something like this. There was one question.
Jumping in.
Yeah.
So I just wanted to mention something based on what you mentioned, which I think is really powerful and true, and resonates with me. I think one really important aspect to look at is when we're having these debates of high income, low income, global north, global south, it's really important to reflect on the historical roots of how these inequities have been shaped, and how colonization and exploitation of global south countries, especially really resource-rich countries in the African continent, over centuries has led to, this economic imbalance that has created a situation where philanthropies and global north countries are even in the position to sort of be philanthropic and decide whether they're gonna donate vaccines or drugs or health workers or things like that. So I think having this perspective of how history has changed these dynamics will allow us to also better view these dynamics, and it's not a lot of philanthropy. It might be what's overdue in terms of what must be done to sort of turn back that sort of exploitation. Thank you.
Yeah, I think that is a very excellent point. Just being in the position of being able to donate or to be kind or to give, that is not because you've just done good work, because it's rooted in inequality and imperialism and colonialism, and we cannot forget about this. Leo, is there something, because it's such an important point, is there something you wanna add to this? No. Okay.
I agree with everything that's been said. Yeah.
And then I'm just trying to go through the. We've touched on Bill and Melinda Gates Foundation. I mean, we didn't specifically touch upon them, but they are one of the big global shapers, and they're setting the agenda. And yes, I mean, as Annika said, they're funding a lot of really important research, but why is it them that they can set the agenda without not being held accountable to anything? And then there was a question. It was just a lot of agreement to the points that we've made. That's also very great. Are there any more questions? You can, if you don't want to ask question in the chat, you can also unmute yourself and turn on the camera, I think even, and then just ask question in.
Yeah, I think if you want to definitely come in and say something, but if you want to add something, you can raise your hand first, and then we can give you the ability to unmute yourself.
I'm just going to wait a couple of seconds because sometimes it just takes a while for people to come up with a question. But maybe I just reflect on when it comes to obviously who's making the decision. And I mean, Leo, I assume it's the same when we talk about transgender people, because they have not been in power positions and they have not been able to drive the discussion either on politics in general, nor on politics and global health. Do you know if is it changing? Are there more transgender people in policy decision making, in particular in the feminist global health sector?
I think it's getting better, generally speaking. I'm not so sure about specifically this context. Also, we don't work globally. We have a couple of projects on monitoring violence globally, like the trans murder monitoring project that we have, but we pretty much work regionally in Europe and Central Asia. So I wouldn't be able to say in terms of the global situation. I think it's getting better, but no, we're still very much out of the picture when it comes to decision making and politics.
And maybe, I mean, Leo and I, we have been also part of, we've been, well, we have spoken in terms of, in the framework of another project. And this is only partly related to obviously feminist global health policy. But the CFFP has been working on a big study on the anti-gender movement. So actors like the Catholic Church, but also the US under the Trump administration, or the Brazil, but also civil society organizations on the ground who are currently mobilizing against the rights of marginalized groups, in particular against feminist movements, LGBTQI movements, and so on. And obviously the feminist health policy is also, it's not one of their targeted issues that they're mobilizing against, but obviously it's part of this. They're advocating against sexuality education in school, which then obviously influences how people who are, how children, trans children, but also gay children and lesbian children then actually have access to information that then improves their health or deteriorates their health. So I think it's really, for me, this was a big learning to always think about the health consequences of everything that we're looking at. And then there was one question, and maybe Sarah, that is one question for you. Are there any feminist global health policy in practice? And maybe you can reflect in general a bit more on where the international debate on feminist global health policy is, because I mean, you've mentioned about Global Health 50/50, and Annika mentioned about movements to decolonize the landscape. But where do we stand when we talk about feminist global health policy from not a civil society aspect, but from a government perspective?
Sure, thank you for the question. So I think that the last point that you mentioned is the caveat that's going to change the answer. So with regards to national policies, there's a lot of shortcomings, unfortunately. There's no really one good example of coherent feminist global health or health policy that is reflected in every single decision in the health sector of a country, or at least none comes to my mind. But I think realistically, there's a lot of progress that's been made here and there, and in bits and pieces of programs. And I think that's sort of the important thing that we really need to build on. With regards to health, it's obviously a lot of it is shaped by national policies, but more and more we see civil society and global health organizations and even private donors that we just discussed to have a more prominent role in shaping these policies and lobbying for them. So I think there are certainly good practice examples. Even in the 2021 report of our organization, we see some of the best practices of how organizations are implementing a feminist or gender responsive or transformative approach to the programming that they do when they try to dismantle restrictive gender norms and transform societies through health. But again, it's examples in specific societies or specific health concern areas, and unfortunately not yet it's not holistic. I just want to point out that with all the numbers that I mentioned and all the discussion that we had, it doesn't mean that we're absolutely doomed. We have to see the other side of the coin as well, that there's a lot that's being done. As I said, there's a lot of momentum. This year is the 25th anniversary of the Beijing Platform for Action, which also pertains to gender equality. And I think it's just all of these conversations show how passionate we are about doing more. I encourage everybody to sort of, if they're interested, obviously, have a look at keywords of global health agenda, feminism, gender equality, and that sort of thing. There's a lot of really good commentaries in BMJ and in Lancet, specifically where they look at intersectional and feminist health policy, and then more specifically in certain areas. I think that's also really interesting and helps us find allies and makes us more hopeful to continue the work that we're doing.
Thank you for also giving us a bit of hope and not only focusing on the negative. Yeah. Annika, is there something you want to add?
Yeah, I do want to add, and thank you for everything you said so far, Sarah. I just, I agree with you that I also, like, I can't think of like a country or somewhere where I would really see like a holistic feminist global health approach. But I did want to mention two examples, because I think when we try to start implementing a feminist global health policy, it can even be like really small things. And I think one of the countries is, for example, Portugal is a country that actually has a strategy, like a national strategy on sexual and reproductive health and rights. And that is one thing that the WHO Europe, I think, I'm pretty sure, has recommended of countries in Europe to implement, to actually have a strategy how to improve sexual and reproductive health and rights within their own country. And then there's another example I wanted to mention is New Zealand, because I think some of you might have seen that just like, I think last week, they extended the rights for like maternal leave kind of, or like sick days for women or pregnant individuals who had a miscarriage. And I think like this, for example, is a very concrete, for me personally, very concrete example of what a feminist approach could look like on a very, very small level. And yeah, so I think there, like if we start looking, there are a lot of these small examples, but I agree with Sarah that we would love to see the holistic and the bigger approach.
And I think the interesting case about New Zealand is then it was praised as like the first country for like a couple of days. And then someone realized that it's only just the first global North country, but there are a couple of actually global South countries. And I think this is a very good example of how unequal this system is when you just don't assume that global South countries did this. Sarah, there was one comment on about global health, that it's a lot about deciding who can give birth and how much, and that the control over populations in the global South is an essential pillar of global health. Also the fact that populations in low middle income countries are often subject to global health experiments in contraceptives and reproductive rights. Is that something you want to comment on? It's not a question per se, but I do think it's an important point.
I mean, I agree with how important this point is. I don't have anything to add, but I know that there's a movement to sort of discuss these injustices more openly in the decolonized global health movement. And I think if we're working in global health, regardless of where we're working or where we're coming from, it's really important, again, to know the history that has shaped this field that was essentially tropical medicine rather than global health, and how tropical medicine was sort of based on not allowing the colonizers to get sick, and that sort of thing. So I think this is also along the same lines, and it's important to sort of understand the reasons behind some hesitancies of communities in recipient or target populations when it comes to certain global health interventions. I think the more we know about the history of our field, the better we can be in it.
Thank you. And then Leo, there's a question for you, because I feel like you have to make this point probably on a daily basis. What would be your recommendations to convince research funding organizations to put money into intersectional research and not just non-intersectional research? I'm sure you have to make this case very often, so maybe you can share some of the arguments that you make.
Yeah, well, I think we've said a lot about this already. I think so. If we don't have the data, if we don't have the information of what's happening on the ground, we cannot really do the work, or the work that we'll do will probably not represent the people we're working for or trying to support. So I think it's crucial. It's just the first step. We need to make sure that we learn and that we understand what people's needs are, and we need to have that data segregated so that we really get to the bottom of things. In that sense, for example, we have the study from the FRA, from the Fundamental Rights Agency on LGBTI people from last year. And there is a lot of work to do there. And we'll plan this year a brief specifically on trans people, trying to disaggregate all the data because we are in one category, all of the trans sample. And we need to make sure that we look into the specifics of certain groups within the trans community. So that's one example of our work and how we plan to do that. And it's crucial that we do. But it is difficult to make the point and for people to understand, because they already get a sense of us being already pretty specific. So asking for more specificity and more details seems like asking too much. But the situation of I don't know, a migrant sex worker is completely different to a white trans man in Western Europe. So we really need to make sure that we're listening to everybody.
Yeah, and maybe I would maybe respond, I mean, depending obviously on who would asking this question, that we're not going to get rid of patriarchy if we're not going to do this. So, I mean, if that is the intended goal, then this is what we need. Thank you so much to all of you. Is there a final statement that you want to make? Maybe you've forgotten something that you want to address that hasn't been paid attention to. So, Annika, is there something you want to say before we close today's meeting?
Well, there is a lot of things that have been said, and there's also a lot of things that have not been said. And I just want to make this point again, that we are always talking about like a holistic approach and trying to represent everybody's, or to account for everybody's rights and everybody's needs. And yeah, all of us, we're speaking like from our perspective kind of, and from our background. So I guess if we would have invited also like 5 other people from other organizations, there would even be more issues that would have been raised. So I just want to emphasize again that this is not an all-encompassing view on what a feminist global health policy would look like and what issues there are. And even us, that we are trying really hard to represent and to think of as many approaches and perspectives that we can think of, we still probably fail to acknowledge all of the issues. And yeah.
Thank you. It's always important to point out limitations of what we're trying to do. Leo, any final words?
Well, I wanted to appreciate your comment about the anti-gender movements and the impact that's having on trans people, and also use the opportunity to also mention how even within the feminist movement, we're seeing some people who are also opposing trans people's rights, and how that's currently a huge issue that we're dealing with right now. So, and coming back to the comment on hope that was brought before, this gives me a lot of hope having this event here today, and seeing that we can work together, that we've been working together already for such a long time, and that we will need to continue doing so. So I encourage everyone to reach out if you need anything. We'll be also developing materials on that topic. If you need extra support, I'm aware that even with the best intentions, sometimes we don't really know how to counter-argue some of the myths that are being brought in feminist context. So please reach out if you have any doubts on the arguments that you're hearing. We'll be happy to support you with that. And again, I appreciate the invitation to this panel.
Thank you so much, Leo. And yeah, we're looking forward to this material, because also, as I said before, like, I've been also raised in a patriarchal environment. I also need to unlearn how I speak and how I think about certain issues. So very much looking forward to this support. Sarah, any final words?
Sure. I'd also like to thank you for the work that you're doing in your organization and for extending this opportunity for me to share my view and the work of my organization. I think just really broadly, it's important, if we're working in global health, to always think critically and question the status quo. And I think that has allowed us to bring in this intersectional or feminist perspective. And I think if you're working in global health, always sort of question what you're seeing and the status quo of things happening, and sort of be mindful if there's no diversity, because global health is inherently diverse, even if it's pertaining to the population of a city in global north that all come from one country. I think it's inherently about social justice and tending to the most vulnerable. So I think all of these conversations boil down to that value, and it's important to be mindful of not participating in echo chambers and sort of always striving to do more and do better for the most vulnerable. It was a pleasure learning from everybody else on the panel and the questions, and I invite everybody to Google Global Health 50/50. There's a lot of toolkits, interactive maps, and resources that you can find there. Thank you.
Thank you. So now it's just left for me to say thank you to our amazing panelists, for Annika for organizing this meeting today, and for the policy brief. For everyone who was here with us today, I can just speak for CFFP, saying that we'll continue this journey and that we'll continue to focus on feminist global health policy. And ideally, we do this with all of you together. So have a good evening or afternoon or morning or day, wherever you are. Yeah, see you soon. Goodbye.